Good morning, everybody, and good evening, everybody, from all over the globe to the Learn from the Legends series organized by IAP, NeoChap, and NNF Kerala. The series known as Learn from the Legends, which meet once in a fortnight with an academic input from all over the globe. I'm extremely delighted to welcome Professor Amish Jain, University of Toronto, Canada, for his enlightening talk on physiological appraisal at the bedside on PPHN. I request Dr. VC Manoj to take over the proceedings from now. A warm welcome to each and every one of you. I'm sure you will enjoy this academic session very much. Over to Dr. Manoj.
Hello, everyone. Hearty welcome to our series. And I have the great pleasure today to introduce a young legend, Professor Amish Jain. Professor Amish Jain works as a staff neonatologist and clinician scientist at Sinai Health System and as an associate professor in pediatrics at the University of Toronto. He is also the site director of the TNE, what we all have heard of this TNE, the Targeted Neonatal Echocardiography Program, which is there in the NICU at Mount Sinai Hospital. Dr. Jain has also completed a PhD in cardiovascular physiology in the Department of Physiology at University of Toronto, and I believe his love for PPHN started since he did his PhD, or I am not sure whether it was there before that. His specific research interests are in the fields of critical care, neonatal cardiopulmonary physiology and functional echo, particularly in the assessment and management of pulmonary hypertension and right ventricular function. Dr. Jain currently holds the Canadian Institute of Health Research and SICKITS Foundation's new investigator research grant for the study of chronic pulmonary hypertension in preterm neonates. He is an investigator. He also has an investigator-initiated research grant from Melanoma Pharmaceuticals for establishing Canadian National Database Program for preterm neonates exposed to inhaled nitric oxide. He also has the Heart and Stroke Foundation of Canada Clinician Scientist Phase 2 Award. He has won this award, Phase 2 Award, for his research program titled Improving Management of Pulmonary Hypertension and Right Heart Function in Neonates. That's the imprint, what we have heard as imprint. He is one of the principal applicants in the two CAHR funded national research projects on evaluation and management of patent ectosacchariosis in Canada. So he is a legend in this field, I must say, and those of us who have heard his talk before knows that he talks very fast but matter of fact. He is also envisioned and co-founded recently launched Neonatal Hemodynamic Research Center, an international consortium of leaders and practitioners in the field of neonatal hemodynamics. So, friends, it's with such great pleasure and privilege that I introduce the faculty for today, Professor Amish Jain. Over to you, Amish.
First of all, thank you very much, Manoj, for that kind introduction. You made two mistakes there. One, you called me a legend, and second, you called me young. I am neither of those two. Thank you very much, and thank you very much for inviting me. And many of my previous mentors, my friends, and some of the people that are role model for me actually have been in this forum and given talks. So it's quite humbling to be a part of their legacy. So I think I'm going to start sharing my screen. How do I do that? I'm just Just give me 1 second.
Sure. While we get the presentation going, friends, unlike the previous times, we have one more session next week. We have this is to make us all available for another legend, Professor Maximo Vendo from Spain. He is available next week only, so we are having the next session next Thursday, not after 2 weeks. Anyway, I hope you must have got the notification already.
Right, let me just try and see this works.
Yeah.
Are we good?
Yeah, we are good. Please take over.
All right. So hi, everyone. As I said, thank you so much for giving me this opportunity. Before I start my presentation, I've got a little disclaimer. Yeah. So I have to disclose that as Manoj also mentioned, I do actually have an industry-funded research group project going on in Canada, where we are developing a detailed database for preterm infants who end up getting inhaled nitric oxide in Canada. It doesn't have anything to do with this particular presentation, except the fact that it's on the same topic. But that's my disclosure. So getting straight into it, and once again, as Manoj said, I do end up speaking a little faster, so apologize in advance. If that is the case, please stop me and ask me to repeat anything that I might have gone too fast over. What I really want to do today is essentially talk mostly about physiology in this particular disorder, which interests a lot of us. And anybody who works in an ICU ends up managing these kids and these conditions quite regularly. And to me, it's a very fascinating physiological condition with a lot of different facets. So before we go into that, just a quick recap. We all know that PPHN is essentially pulmonary hypertension in the first couple of days of life. Although it is an acute pulmonary hypertensive crisis, what distinguishes it from all other populations is that unlike later in life or later in postnatal course for newborns, where a patient who has had normal pulmonary pressure for a long time has an acute rise in pulmonary pressures and hence have an acute pulmonary hypertensive crisis, in this setting, there is nothing rising. It's basically a failure of dropping from the high pulmonary vascular resistance in the fetal life, which creates a very unique type of physiology and also a bit of a diagnostic challenge because high pulmonary vascular resistance or high pulmonary pressures on the first day of life is pretty normal also. So distinguishing the normal versus abnormal can be sometimes a little bit tricky. And which is why it's always taken in the clinical context to call it a PPHN as a syndrome. So as just a quick recap of what type of circulation we are dealing with in these scenarios when the pulmonary pressure are still high, when they should not be. You can see here, essentially the blood is coming from the IVC and the SVC into the right side, which is deoxygenated blood coming back from the great veins. And because the right atrial pressure is higher than what it should be, a part of that blood actually shunts across to the left side, which is deoxygenated, resulting in a bit of mixing in the left atrium, sort of bypassing the fetal circulation, or not the fetal, bypassing the pulmonary circulation. Now, another big chunk of the blood, if the shunt is open, can actually bypass the lungs again through the patent ductus arteriosus, which is present in about 75-80% cases with PPHN. And in this setting, this blood is going down to the descending aorta and getting mixed again and creating a hypoxic mixture in the descending aorta. The remaining blood does go to the lung, but because the lung's pulmonary vascular resistance is high, it doesn't oxygenate as well. So you got some partial oxygenated blood coming back to the left heart. And then the body ends up getting a little bit of a hypoxic mixture. So you can see why that would be a major clinical problem. We used to call this persistent fetal circulation simply for this reason, because the shunts makes it a very unique situation compared to what a pulmonary hypertension would be otherwise in any other patient population. So, which is why it's a clinical phenotype. PPHN is not an echo diagnosis. And the way I physiologically think about it is that it's a failure of normal postnatal adaptation with a persistently high PVR, leading to a pulmonary to systemic shunting of blood and then clinically presenting at hypoxic respiratory failure. So you need to have all these things together to be able to call it a PPHN syndrome. And they do end up coming together. But their cardiopulmonary sequelae can be very varied. And I'm going to spend a little bit of time on this particular slide, not because I spent a lot of time in making it, but because I think that's one of the key learnings I had over my career as I was looking after these kids, is the interplay between various cardiopulmonary sequelae, and it varies from patient to patient. Not every patient suffers from the same phenotype. However, there are patterns that will emerge from this, and I'm hopefully will be able to share a couple of cases to actually make my point there. But I do apologize for being a little boring here, but physiology is a bit like that sometimes when you're thinking about it. So as I said, the main problem here is high PVR, which is the right ventricular afterload. And what that does, as we saw in the previous slide, is because of a very high afterload, which the right ventricle may or may not be able to adapt to, it can cause acute right ventricular systolic and diastolic dysfunction. If the PD and PFO are open, the high PVR will result in shunting of the blood to the systemic circulation. That shunting of the blood to the systemic circulation means that it is bypassing the lungs, and hence the pulmonary blood flow can drop down from this. The good thing is that the right to left shunts actually protects the right ventricle from failing, because it offloads the pressure load that it is facing. So there is some protection from that point of view. So in a way, it's a bit of an adaptive mechanism to keep the heart going despite having very high afterload. But it does come at a cost of low pulmonary blood flow. Now, the RV systolic and diastolic dysfunction itself can give you low cardiac output on the right side, and also will increase the filling pressure in the right side. So the filling is not that easy. And in together, it results in a situation where you could have quite low pulmonary blood flow. And if the pulmonary blood flow is low, then there is a VQ mismatch. The VQ mismatch will produce hypoxemia, and hypoxemia will produce acidosis. Also, the less goes in the lungs means the less coming back to the left heart. So the left heart preload gets compromised. And because neonatal myocardium is very load dependent, low preload, if significantly low, can result in LV systolic dysfunction and also reduce your cardiac output from the left side. Also, they have interventricular dependence, which means one side of the myocardium can affect the other side function clearly. So what you can have is the RV systolic dysfunction, because there are shared myofibers between both sides, can on its own affect the LV dysfunction also. And the net result in the most severe cases is systemic hypoperfusion and shock. So you have hypoxemia, hypoperfusion, and shock situations. So as you can see, it's a little bit of a complex interplay. But the good thing is that not every patient suffers from all of these sequelae. And I will show a couple of patterns that I've learned over my career. And they do fall in about 3-4 different patterns most times. Now, we all know that inhaled nitric oxide for the term and near-term infants is more or less a standard of treatment, well proven by trials to actually reduce the outcome of death or need for ECMO. So to be honest, in our practice, majority of time when I get involved in these cases is when it actually hasn't worked. And it does happen quite frequently. In about 35-40% of cases, the hypoxic respiratory failure persists despite inhaled nitric oxide treatment trial. And it is those cases where things get really interesting and scary at the same time. So I'm going to primarily restrict to those type of patients, not the patients who are on hypoxemia, got nitric oxide, and half an hour later to come down to room air and are perfectly fine thereafter, because they are sort of a standard practice right now. So as I was saying, that the management principles of these patients who are unresponsive to ventilation or inhaled nitric oxide combination or a pulmonary vasodilator of your choice can fall in different categories, and why the hypoxemia persists and why they have not responded to a pulmonary vasodilator therapies could mean different things. It could mean for some patients that their pulmonary vascular resistance is still high despite one therapeutic agent, and really their primarily phenotype is determined because of that, because they've got a VQ mismatch and everything else is fine. The heart is coping, the function is okay. And in those situations, you clinically tend to go more towards trying to give additional pulmonary vasodilators, trying to address different pathways to get some synergistic effect. And if we can relax that pulmonary vascular bed, things might improve. Obviously, we have to think about systemic side effect, because beyond the inhaled nitric oxide, there is no other proven, at least, selective pulmonary vasodilator. So we'll have to give it systemically, and we'll always have to balance that risk of vasodilatation, systemic vascular bed, with the need for pulmonary vascular relaxation. So that's one phenotype. The second phenotype is that there are patients who actually don't improve despite pulmonary vascular, despite INO, is because they have a huge amount of shunt, which actually is in addition to the high pulmonary vascular resistance, which is causing the pulmonary blood flow to be quite low. And in those situations, our goal is not just to reduce PVR. We start focusing more on PVR-SVR ratio, with the intention that we are trying to reverse the shunt. And if we can push some blood in the pulmonary vascular bed, that will improve the VQ mismatch, and quite dramatically sometimes can improve hypoxemia, and hypoxemia improve acidosis, and the pulmonary vascular resistance also improves because hypoxemia improves. So the vicious cycle gets broken up by our ability to actually bring down the PVR-SVR ratio, sometimes by reducing PVR, and other times by increasing SVR above PVR, or a combination of both. So it does tell us guide our management. In other situations, we will find that the reason the hypoxemia has not improved or the pulmonary blood flow is low, because there's a major contribution of cardiac dysfunction. There is a systolic dysfunction, and there's a pump failure, or there is a preload problem, because especially when it's occurring in association with the vasodilatory shock. And in those situations, our primary target becomes fixing the pump by using inotropes, or by giving an agent to improve the preload, in addition to obviously trying to reduce the pulmonary vascular resistance. So this particular algorithm that we developed does help us to some way. Now, in terms of specific pulmonary vasodilators, now I'm not going to go into each pathway. I'm sure all of you are already aware. They're well-published pathways, and from which many drugs have been developed. As everybody knows, there are 4 key pathways that determine pulmonary vascular tone, and has resulted in discovery of these therapeutic agents, which are quite routinely used in adult population. Not a lot of data in neonates beyond the large-scale trials for inhaled nitric oxide, but there are small trials and case series showing efficacy of sildenafil, for example, by inhibiting phosphodiesterase 5 enzyme here, which increase cyclic GMP. Prostaglandins have been used, which actually cause cyclic AMP pathway and increase cyclic AMP production. Prostacyclin has been also used. There has been inhaled prostacyclin used as well. PDE3 inhibitors like milrinone actually inhibit this enzyme here, increase cyclic AMP, which can act synergistically and cause vasorelaxation. Bosantin has been used in small studies, which basically look at the endothelin pathway. And the Rho kinase inhibitors like Fasudil has not been described to my knowledge in the neonatal population, but certainly has started coming out in the adult population. So we do have a bunch of therapeutic agents to choose from, but which pathway we want to go, I guess depends a little bit upon your personal experience and sometimes your personal choice. What about the cardiovascular approach? Now, as I was training during my fellowship in UK and subsequently here, there was a belief in our society, and people have recognized that an increase in mean blood pressure can improve oxygenation. I tend to call it pressure-pressive oxygenation, which means that the blood pressure-dependent oxygenation. And the reason this oxygenation is dependent on that is because the pulmonary blood flow is dependent on that. And there was a belief that if I increase the SBR, the shunt across the PDA will reverse. And historically, at least in my experience, people used to use fluid boluses and dopamine to increase the blood pressure, with the idea that if we increase SPR, we will reverse the shunt. It didn't really work that well at that time, and why that might be. Well, one of the challenges here is that whatever we are doing to increase the patient's SPR, we got to think about both SVR and PVR, not just SVR. The challenge is the SPR is more easily monitored by monitoring invasive blood pressure. And we can give a drug, the blood pressure comes up, we think we have done the job, but we are not able to monitor PVR at all because there is no catheter being placed to monitor PVR continuously. So what we don't know is what the ratio is doing with those drugs. And that complicates things because we do induce increased blood pressures, and then sometimes it works, but a lot of time it doesn't work to improve oxygenation. And is that a failure of the cardiovascular approach, or is that because the PVR-SVR ratio was not important for that child? So my learning is that you got to always think about what you're doing and what impact on PVR it may have, and if possible, evaluate it. So we know, for example, from animal studies that dopamine, particularly in the context of hypoxia, can increase or does increase PVR in addition to SVR, and the ratio might not change much. If you look at the preterm studies for PDA and transitional hypotension, pre-post echo studies, they also demonstrate that dopamine use can have different effects even in preterm. While in some population, the PDA shunt volume goes down quite a bit, suggesting the dopamine has increased PVR. In other patient, nothing changes. So it can have quite variable effect of PVR on PVR, but it certainly increases it, and it increases it by alpha-1 receptor agonism. What about other agents? Norepinephrine has been tried and has been suggested one of the agents. We don't really have much data on it except for this paper, which actually did a pre-post echo study in PPHN term newborns, about 22 in number. And what they were able to show is that the ratio of the mean pulmonary artery pressure to mean systemic arterial pressure actually remains stable and same for a lot of patients, but come down for quite a few patients, but also goes up in some patients, which means norepinephrine in this particular study, at least, it increases the mean pulmonary artery pressure in everybody. So we actually worsen the problem, but it did increase systemic arterial pressure more in a significant subset, keeping the ratio, bringing the ratio down overall. So if the ratio is the goal, then it might do a better job than dopamine. That was a conclusion. But what about vasopressin? Now, this is a drug that has interested us a lot in this particular context. And that's because of its physiology. Now, this is a paper from 2016, where this was done in children who already had the diagnosis of primary pulmonary hypertension. And what they did was, as a part of their routine catheter examination, they tested the impact of a bolus of 3 different drugs on PVR, SVR, and the ratio. And the idea was that when these kids go into pulmonary hypertension crisis and PICU, which drug would be a better drug for them? And that's what that's the rationale of the study. Obviously not a big study because it's an invasive study, but you had 5 kids in each drug. I won't go into phenylephrine because we don't use it much. But you can see here, the patients who got epinephrine actually had variable effect. They all increased their aortic pressure, but a bunch of them also increased their pulmonary pressure. So the net results of pre and post PVR SVR ratio, although remains same or a little bit down in some patients, it did increase in some. So the effect was a little bit variable, and in some cases quite a bit. But when they looked at vasopressin, the bolus of vasopressin increased systemic blood pressure in everybody, but did not increase appreciably pulmonary pressure in anyone, and in fact brought it down a little bit. So if you look at the PVR SVR ratio here, for each of those 5 cases, it came down. And their conclusion was that vasopressin probably is a better agent for pulmonary hypertensive crisis in children with primary pulmonary arterial hypertension, as it consistently brings the PVR SVR ratio down compared to other cardiotropes where the effect may be more variable. We certainly have seen that in our population also. And there's a reason, because vasopressin is well proven, has a well-proven physiological effects, that it does vasoconstrict vascular beds, but not the pulmonary vascular bed, not the renal vascular bed, not the coronary, and not the cerebral. And these are kind of important vascular beds for our patient population. So we do actually have, we thought at least, that we have an agent which can increase your blood pressure and might be able to bring your PVR SVR ratio down more consistently than the other cardiotropes. which is why we have been using it as a first line agent in all these scenarios, unless it's contraindicated for some reason. We publish, but the actual evidence or actual data is limited. It is only limited to case series. So we, from our center, Dr. McNamara, one of my ex-colleagues now and friend, actually published a case series of INO unresponsive term babies, showing that after starting vasopressin, their oxygenation improved over the next 24 to 48 hours. We have recently demonstrated the same thing from our center in preterm babies. We don't really have a trial or any good quality evidence to say that we certainly could recommend it strongly, but certainly from a physiological perspective, it makes more sense. So with that, I'm going to take a little pause and just share our approach in terms of clinical applicability of various cardiopulmonary agents that we tend to play with, so to speak. By no means I'm saying that this is I'm providing a recipe. This is just our approach that we have developed over here. And people there are more than one ways to skin a cat. So it's only fair that people may use slightly different methods. So sildenafil, for example, it reduces PVR, it reduces SVR. There is data enough to say that it might actually improve PPHN equivalent to inhaled nitric oxide in small trials. People have also demonstrated that it could be used in conjunction to actually help patients wean off nitric oxide who are having rebound hypoxemia. So it is an alternate pulmonary vasodilator. It can help you come off inhaled nitric oxide. The downside is that it does reduce your blood pressure, so you'll have to watch out for hypertension. Milrinone, another agent that we use quite a bit in our practice, it reduces PVR, it reduces SVR. It is a positive inotropic agent. And it also improves cardiac relaxation. So it improves your diastolic performance, which is often referred to as lusitropic. So we use it in normotensive patients who have high pulmonary vascular resistance and evidence of LV systolic dysfunction. The limitation is that it is contraindicated in hypertension. If you already have low blood pressure, it's gonna decrease it further, and hence you cannot use it till you fix the blood pressure first. And the other thing we have learned the hard way is that when you have HIE PPHN patients who are being cooled, milrinone seems to precipitate systemic hypertension quite dramatically. We don't truly understand why. Perhaps either their response to the drug is much more, or perhaps their pharmacokinetics are a little bit different. But we certainly are not using it in context of therapeutic hypothermia. Or when we are really using small doses and going up slowly, because we've had few cases. And we have shared this with other people around the world, and they have had the same experience, that it does precipitate hypertensive crisis in patients undergoing therapeutic hypothermia. Epinephrine, low dose epinephrine up to about 0.1 is a positive inotropy. It works on beta receptors and have got no alpha effects. It actually has been shown to have no effect on PVR at that dose. In fact, people have suggested it might even actually reduce it because of its beta effect from a vasodilatory perspective. But the moment we go higher, particularly more than 0.12, it becomes alpha agonist, and then it actually does improve your SVR and PVR quite a bit. So we tend to use it when you have severe cardiac systolic dysfunction and low cardiac output, but we only use low dose. We don't use high dose epinephrine in this context ever, because it almost invariably increases your PVR and SVR. Norepinephrine, it increases SVR. It does increase PVR and quite consistently, but the data suggests that it increases SVR more than PVR, so it might actually help in reversing the shunt ratio. Particularly if we are not able to use vasopressin for some reason, then that will be our go-to drug for improving blood pressure in this patient population. Also, if we are having PPHN crisis in association with a sepsis, for example, which causes vasodilatory shock, and we also want to provide a pressor support, then that's our go-to drug. Dopamine primarily is an inotrope because it works only on beta receptors. So we tend to use it in mild, moderate cardiac dysfunction and borderline low cardiac output when it is not severe. And the reason for that is the data in newborns, particularly on the right side of dopamine being able to improve the function, is very limited, and we don't really know whether it works as well as epinephrine does. And the other thing is that when you go beyond 10 mics per kg, it does induce tachycardia. which can increase your cardiac oxygen consumption. So we tend to use it in mild, moderate cases. In severe cases, we go for low dose epinephrine. And finally, vasopressin, which definitely increases SVR and definitely does not increase PVR, perhaps even bring it down if you believe the animal literature. And in our practice, we use it for shunt reversal and treat hypotension when it is not contraindicated, particularly when hypotension is occurring in the context of persistent HRF. And we really don't want to worsen the SVR PVR ratio at all, provided there is no LV pump failure. There is some hesitation. If you have LV pump failure, by increasing SVR, you might make it worse, although I haven't seen it that. But we tend to use a low dose of epinephrine in those situations anyway to improve the pump function first. So that's our approach to various agents that we tend to have available to us. But as you can see, our approach is dependent upon physiology, and physiology is not easy to know at the bedside because from a phenotype point of view, it's always hypoxic respiratory failure. Whether that's because of PVR high, whether it's because of shunt fraction being high, whether it's because of pump failure, it's not easy to tell clinically. So recently we did ask this question by comparing clinical predictors or by comparing clinical markers of patients who had echo for PPHN. And we divided those patients into those who have severe RV dysfunction versus who don't. And the idea was to see, are there any clinical markers that we can then tell to clinicians that these markers indicate underlying cardiac dysfunction more than not. And you can see here, we couldn't find anything. All the clinical markers of cardiopulmonary sufficiency were similar, independent of echo showing severe RV dysfunction or not. So there really wasn't a clinical marker that we could find. When we looked at the correlation between RV function and clinical indices, there is a weak but correlation between RV function and respiratory parameters. So if your FiO2 is high, if your respiratory severity score is high, that may indicate a lower RV function underlying, but really the correlation was quite weak. So really it left us to the point that clinical assessment alone, though it might help to some extent, it does not allow for accurate evaluation of the nature of cardiopulmonary compromise. And there is a need. There's a need for comprehensive echocardiography to be used in this patient population to be able to decipher what is the underlying pathophysiology. Again, we're not going to go deep into this, but overall in an echo, we can think about three things. We are in this patient population. We are evaluating pulmonary pressures by various means listed there. We are evaluating its impact on RV performance, and we are evaluating its impact on system performance. So any sonographer or anybody who's involved, these are the things they typically measure as a marker of performance here. But physiologically, and this is what I tend to teach my fellows, when we are doing a detailed functional echocardiography in this patient population, what are the physiological questions we are asking ourselves? Well, the first question we are asking is there PPHN? Because you can have hypoxic respiratory failure from parenchymal lung disease alone without significant contribution from pulmonary vascular disorder. So that's the first thing. Once we've confirmed that, yes, the patient does have significant pulmonary hypertension or PPHN syndrome, then the next question is we divide our thinking into right heart assessment and left heart assessment. On the right side, we're asking ourselves, how is the right ventricular systolic performance? Is the pump performance okay? Then next we are asking is the right ventricular output compromised? And they don't always go together. You can have a normally functional but low output because that output low can be coming from preload. So less filling could result in lower output. And that's why when we find low cardiac output, we think about the preload. Is the chamber size okay? Then the next question we ask is, could the pulmonary blood flow be low despite having normal RVO? And that can happen because of PDA shunting right to left. And the way we get a little bit of indication by that is by looking at pulmonary vein velocities as they enter the left side. So if you have a normal right ventricular output, a large PDA shunting right to left, but the pulmonary vein velocities are very low, that is a surrogate marker of a significant runoff from the PDA resulting in low pulmonary blood flow. And then we ask ourselves, is the RV dilatation there or not? Then on the left side, we're asking the same things. We are asking, is the left atrial filling compromised? What are the pulmonary vein velocities? Is there an ASD PFO which is shunting right to left and hence supporting the LV filling? Is the LV filling compromised by adverse VV interactions, which is ventricular-ventricular interactions? So the RV can dilate, push the LV inside, and because of a very stiff pericardium, the LV becomes smaller in capacity and can't fill very well. How is the LV systolic performance? And is the LVO compromised? So we are asking all these questions in then one scan. And once we have our answers of what is the underlying pathophysiology, we always try to correlate back to the clinical problem. Can this abnormality that we just found inform or go with severity of hypoxic respiratory failure and the shock that we are seeing clinically? And I'm going to sort of quickly demonstrate this by two of our cases. These are real cases from our practice, and there are many like these. I just chosen two to actually make the point. This is, for example, a 36-week baby who was delivered by section because of long-standing anhydramnios as early as 15-week gestation. The kid was born, was vigorous, but has severe hypoxemia, which, as you can see, didn't resolve by either non-invasive or invasive ventilation. Pretty high mean airway pressure, high amplitude, but the FiO2 was still 100%, and was given inhaled nitric oxide at 40 minutes of age, had no response. Was given surfactant at 70 minutes of age, had no response. You can see the blood gas is terrible, the first one. And the kid was given a bolus for poor perfusion, but his blood pressure were completely normal, and there was no pre-post ductal saturation difference. So I got a call at about 4 hours of age to evaluate this patient. By that time, the patient had received further boluses, has been muscle relaxed. His ventilation is bringing CO down, was still high, but getting better, but has severe acidosis. And even now the blood pressure were normal and people have started bicarb correction. And this is the echo. I'm just showing a couple of pertinent images. You can see this is a short axis view. This is the left side. This is the right side. If you look at the right side closely, the cavity is not changing in size in systole. So basically, it's not contracting. It's got severe RV systolic dysfunction. The LV is contracting, but it's not great. So it's got moderate LV dysfunction also. We look at his tricuspid regurgitation, it gives us a pressure of 77. So it actually had high right ventricular systolic pressure. We look at his right ventricular output. This is the RVOT Doppler, was quite low. 69 is quite low. And we looked at his PDA shunt. You can see here, his PDA shunt was very low velocity, but left to right at that time mostly. And the right to left component was not much. And his LVO was also borderline low, was better than RVO because his PFO was shunting right to left and supporting his left side. So from this, we were able to cast physiological impression that the PPHN is confirmed. The PPHN is complicated by low pulmonary blood flow, as we can see in the low RVO, as well as low pulmonary vein velocities, and there is a pump failure. The pump failure is most likely responsible for low pulmonary blood flow, at least to some degree, because of low RVO. And the PDA shunt is not contributing to low pulmonary blood flow because it's not right to left much. And in fact, it might be actually slightly supporting it. The PFO is supporting LVO, possibly contributing to low RVO. So based on this impression, we titrated our clinical approach, and we say our therapeutic target basically became improved pump function and try to reduce PVR, but avoid agents which may worsen PVR or precipitate hypertension. You don't want a systemic hypertension when you already have pump failure, because you do need coronary circulation to the myocardium. So what we did was we basically said, despite no response to INO, we continue it because there is severe PPHN and we might not be seeing a response because of underlying cardiac dysfunction. We started the patient on low dose epinephrine first, and then we monitored gas and lactate and told the team to increase the epinephrine slightly, keeping it low dose to titrate to your lactate levels. And this is what happened. This is where we did the echo and epinephrine. Over the next few hours, the FiO2 came down to about mid-40s. By this time, the patient's blood pressure was quite robust. Things were getting better. Pulmonary hypertension was still there, not completely resolved. So we added Melanoma because now the patient can tolerate it because of systemic blood pressure, and it's just kept improving. And this has all happened in about 30 hours. The patient was in room air, actually extubated 3-4 days later. and went home. So it does actually help us turn these patients around if we know what the underlying pathophysiology might be. Interestingly, and we focus on this a lot in clinical practice, pre-post saturation differences. This patient's pre-ductal saturation difference was never above post-ductal throughout. And why that might be? So first of all, it tells us that the absence of pre and post-ductal saturation difference does not rule out PPHN. So it's important to understand physiologically what is happening at the pre and post saturation difference. All it's telling us is there's a significant amount of blood going from the pulmonary circulation into the systemic circulation at the ductal level. Now, for the saturation difference to come through clinically, there has to be significant volume. So any condition which may reduce the volume of blood going to the PDA can give you a normal or not normal, can give you equivalent saturation despite having PPHN. So RV dysfunction, low RVO is quite classical. These patients almost never have a high preductal and postductal because there's just not enough blood flow going through the duct at all. Some patients may have small PDA or no PDA, or they may have bidirectional PDA that the net blood flow across it is basically equal. So these situations, you may have it. And obviously, you may also have it because there is no PPHN, but it doesn't rule it out. Another case, 36-week IUGR kid, to cut the long story short, had severe respiratory distress at birth and hypoxia, which was not resolving. Got surfactant, transiently improved FiO2 to 60%, but then went back up to 100%. High CO2 in the cord gas minus 13, but you can see first gas CO2 was pretty okay, not that bad. And this kid actually had a pre-ductal saturation difference more than post-ductal by about 10%. Blood pressure was soft, not low, but they were soft for a 36-weeker, mean of about 35, 36. And we scanned this kid, and you can see here, this is again the left side, right side. And if you compare to the previous one, you can see the right side is actually quite dilated. Again, severely dysfunctional, but the left function is pretty good, but it is small, small cavity size. And the same thing can be very clearly seen in the 4-chamber view here, right side, left side. And the PDA shunt in this patient was primarily right to left with a big volume. So what we noted was that the patient has severe RV systolic dysfunction, but also has dilatation. The LV function is completely normal, but the LV is smaller volume because it is pushed inside by the RV. The PDA is shunting predominantly right to left and is high volume. The PF was also shunting right to left and perhaps supporting the LVO a little bit. So interestingly, the LVO in this patient was normal, in normal range, and so was the RVO. 151 for that age is normal, right ventricular output. And despite dysfunction, his output was normal, and that's because he was dilated. So by Frank Starling's mechanism, he actually was able to compensate his right ventricular pump function or output by just dilatation. But this patient has extremely low pulmonary vein velocities, which told us that there's a big runoff from the PDA. So again, physiologically, we confirm PPHN. We confirm that it is complicated by low pulmonary blood flow because the pulmonary vein velocities are very low and a pump failure of the right side. But the pump failure is not necessarily causing the low pulmonary blood flow because the RVO is actually maintained and is compensated, at least not the primary mechanism. However, the PDA shunt is a major contribution to low pulmonary blood flow because it is actually running off quite a bit of blood. And there is an adverse ventricular-ventricular interaction. So based on that, we titrated our therapies. Primer goal became reversal of PDA shunt. So we wanted to reverse this PDA shunt either by reducing PVR or by increasing SVR above PVR, such that the PDA shunt becomes less left to right, right to left, and more blood goes in the lungs, with the hope that will improve VQ matching, correct hypoxemia, which will itself reduce PVR because the hypoxemia gets better. And we wanted to actually improve the RV pump function. However, we didn't think it was clinical. We thought it was subclinical in terms of its contribution to patient's phenotype. So we started INO. We also started vasopressin in this particular scenario because the BP were in any way soft, and we wanted to increase the blood pressure a little bit more, and also wanted to reverse the shunt, so it actually fit the bill perfectly. And what we told the clinical team is to titrate the dose of vasopressin to two things. One, increase the blood pressure, and second, the pre-post saturation difference will resolve. And third, because the clinical team wanted to support the right ventricle, we started a low medium dose dobutamine, and we just kept it same. And this is what happened. So this is when we started the vasopressin in this kid. Over the next few hours, the FiO2 came down from 100% to 90 to 80 to 70 and 80 in between. And when the blood pressure became robust, we started him on Melanoma at here. And that in combination with vasopressin actually created a dramatic improvement over the next 4 or 5 hours. And the kid went down to 30%, 25%, and down to room air after a couple of days. And again, got extubated in 3 days and was never looked back. So I hope I've been able to sort of demonstrate how the bedside physiological appraisal makes a difference in these patients' care. At least we think so. Will we be able to do a trial on this? I don't think so. I don't think you will be able to have enough patient population to do a trial on each physiological phenotype. However, an appropriate use of echocardiography, either by a neonatologist or by an interested cardiologist, doesn't matter, could really help the clinician fine-tune what is the underlying pathophysiological mechanisms and where to target their therapeutic approach with the idea of turning these kids around quickly and reducing their intensive care burden. Some other sort of bedside considerations that to think about. People often discuss these things, whether we should use HFO or conventional ventilation in PPHN. And to be honest, there's only one trial in term babies which actually had only INO, only HFO in combination. And what they demonstrated that was that overall, a combination of INO or HFO did improve the PaO2 the most. But when you look at underlying pathophysiology or underlying diseases, it really was important in patients who had parenchymal lung disease. In these scenarios, the response rate was much higher in a combination of both, probably because you're getting better recruitment and hence better delivery of INO. But in patients who had no parenchymal lung disease, who had like primary PPHN without a major parenchymal component, there was no difference. So really, you got to titrate your to a particular patient you are catering to. What we tend to do, we tend to use the supportive management goals in this order as I've highlighted here. We are trying to maintain normal or actually slightly elevated PaCO2, not hypocarbia for sure, but we have sort of with time become a little bit more tolerant with the PaCO2 approach. Particularly, we have learned from the CDH literature, where tolerance approach gives you better outcome than trying to bash the lungs and bring it down too much. So in our clinical practice, 45 to 60, even 65 sometimes, we don't try to bring it down anymore. Obviously, we got to find the right balance between lung expansion and over distension. So we've got to use your chest X-ray, although it's not quantitative, but you certainly can use it qualitatively. FiO2 is oftentimes used as a marker of lung aeration, but it is misleading in PPHN because it won't come down. So what we tend to do is use the mean airway pressure judiciously, increase it to see if any additional benefit is achieved. But if not, leave it at the pressure where any reduction causes worsening, but any increase doesn't make anything better. So we leave it at that, provided the CO2 is a normal range. We correct acidosis, do not induce alkalosis. Typically for term patients, we are accepting 7.3, 7.4 pH, but in preterms, even more than 7.2, I'm usually okay with. And obviously, good use of sedation and muscle relaxation, not overuse, but at least in the beginning, to remove the contribution of spontaneous breathing to your PVR. What about oxygen saturation targets? Well, if you look at the data from lamb experiments way back in 1960s, hypoxia does increase a PVR quite a bit. And what this graph basically shows is a relationship between pH, PaO2, and PVR. But what you see is that at any given pH, approximately 50 at the pressure of 50 mmHg in the arterial sample, the PVR has come down to its lowest it could have, and beyond that there is not much reduction. So basically saying that you want to avoid hypoxemia for sure, but hyperoxia doesn't help. More recently, from one of my role models, Satin from Buffalo, he conducted a lamb experiment, different animal species, 4 decades later, still exactly the same results. The PVR and arterial PO2 relationship in PPHN in lambs was exactly the same cutoff point, 50. Anything below that increases PVR exponentially, but above that, the reduction is not much. And when we converted that into saturations, because that's what we're going to use clinically, the PVR in PPHN lambs came down consistently up till a saturation of 90-91, and nothing much changes after that. So, and in fact, at the very extreme, when it was hyperoxia, the PVR tend to start going up again. So what we learned from these experiments and from this data is that we want to avoid hypoxia. We want to avoid hyperoxia. We just want a saturation range of 90 to 95 should be able to do it. And there is data for that. In 1980s, these guys, this was in children, they tried to correlate the PaO2 data to saturation data to understand where can we find no hyperoxia and no hypoxia. And they came up with the same range, 90 to 95. Below 90 saturation, your PaO2 may be normal, but it could also be quite low and you would not know. And the relationship is not linear. Above 95, you could very well have hyperoxia, and saturation could be 97. But 90 to 95 seems to be the place where there was no hyperoxia or hypoxia for the most part. So that's what we use clinically. In our practice, 90 to 95 saturation range is what we are using the oxygen therapy for. We don't use more than 95. And most places have stopped using that also, as I understand. The other thing to think about is the right ventricle is really vulnerable to afterload. This is data from adults. And for reasons that I'm happy to go as a part of discussion later if you want, the ejection fraction of the right ventricle will go down quite dramatically as the pressure it's facing increases, but the LV goes down more slowly. So it's a very vulnerable side, and pulmonary hypertension, you really have to focus on that. We have demonstrated in our small PPHN sort of retrospective analysis that early right ventricular dysfunction noted by TAPC actually was more common in patients who end up dying or needing ECMO versus those who not. But this is small data, just preliminary data, but it does seem to be important. So in summary, we need to remember PPHN is not just elevated PVR, it's a heart-lung condition. So it's about elevated PVR and impaired myocardial performance. We have to consider all factors that contribute to it. Use oxygen, mechanical ventilation judiciously. INO is effective in improving in a proportion of patients, but we need to, all of us need to have an effective approach to INO non-responders because their numbers are quite a lot. And TNE evaluation, particularly early in disease process, can actually help us in telling us what is the nature of hemodynamic instability. And I'm not saying that you must use the approach that I'm using. You can have your own approach, and if it works just as well, but at least we should have an approach, which is we need to consider cardiotropic support, normalize pump function, and really focus on not increasing PVR by our therapies. And I would recommend that you got to proactively look what is the RVO, what is the pulmonary blood flow, how is the RV function, and what are the shunt contributions. And putting all of that together, individualized management based on physiology. And if things are not working out, revisit what we understood or what we presumed the physiology to be. And because it's not easy using non-invasive means, sometimes we do get it wrong. So rather than keep going down the same path, it's prudent that we go back and reevaluate and try to see whether we got it wrong the first time around. And with that, I'm going to stop. I'm sorry I've taken a bit longer than I anticipated, but I'm happy to stay on for Q&As. Thank you, guys.
Thank you so much, Professor Amish. It was a wonderful talk, very informative. You have briefly summarized the whole concept. Now, may I invite two great neonatologists, one from Qatar and one from India. Dr. Kiran Murray, he is a professor at Well Cornell University, Sidra Medicine, Qatar. And Dr. Kavita Srikumar, she is a professor of pediatrics at Government Medical College, Goa. Over to you, both of you, to take over the session to moderate the question answer session.
Thank you, Manoj. Thank you very much. If Kavita, if I can just make a start, and first of all, congratulations, Amish. Excellent session. It was really enlightening. I think every time we see a different speaker, expert talking on this topic, we always learn new things, and I quite learned good new things from it. Before going on to the question, I think just for summarizing what the Amish has nicely summarized, it's a PPHN is kind of a clinical phenotype which we need to understand. It's not only the echo findings, and we need to understand what clinical phenotype baby is presenting. and how important echo-based understanding, whether it's an increased PVR or is an increased shunt, which is causing the problem, or is it the cardiac dysfunction? And use your inotrope wisely and I think everyone should know what agent they're using and what effect it's causing on the SVR and the PVR as well, because we can monitor the SVR and the systemic blood pressure, but as Amish rightly pointed, we don't know what's happening with the PVR, and that's why sometimes babies don't respond. And I think another couple of important points, Amish, you made was, a lot of time people not doing echoes, let's look by pre and post ductal difference. And, just say that maybe there is not PPHN, but there could be RV dysfunction underlying, or really it is interplay of how the shunts are happening. So that's why, again, it is coming to the fact that how echo-based decision making is very, very much important. So without wasting much time, lots of questions. I can see a lot of interest has been generated. I will just start with, we'll take questions, Dr. Kavita, one by one. I think somebody posted a question very early on about the grading of pulmonary hypertension. Is there a mild, moderate, severe grading, and what sort of numbers we look at based on the echo to grade the pulmonary hypertension? Over to you, Amish.
Right. Yes. I was recently doing a study and writing a grant application, and one of the things they asked was define PPHN based on RVSP. And to be honest, I couldn't come up with an answer. And despite about 40 years of studying this disease in various models, there is no real categorical answer of what is the cutoff that PPHN, because as Kiran rightly pointed out, PPHN is a clinical diagnosis where you have to have symptoms and pulmonary pressures. We all see patients who have got high pulmonary pressure on day one, but they're completely fine, particularly IUGR kids, for example. Do they have PPHN? I don't think so. They have high pulmonary pressures, but they don't have PPHN. So I'm sorry, but there is no cutoff. As far as mild, moderate, severe goes, people have come up with their own definitions for clinical context. We don't try to do that. The most typically used definition is by relationship of pulmonary pressure to systemic. So if you are suprasystemic, or whether you are near systemic, whether you are infrasystemic, and that's coming from just qualitative appraisal from cardiologists, but that is useful for later on. But for example, somebody has a 60% systemic pressures at 8 hours of age. That's totally okay. That may not mean severity. But we do, in my practice, I tend to say suprasystemic plus cardiac dysfunction is severe. Suprasystemic, but everything else is good, I call that moderate. But to the patient, it doesn't matter what I call them. They still have hypoxemia, right? So, but if you have so half systemic and normal functions, then I basically just call it no PPHN, to be honest.
Perfect. So yeah. Okay, over to you, Kavita.
Professor Amish, excellent talk. We couldn't even 1 second we couldn't not hear it, not get distracted. Yes. So there is a question by Dr. Jain. I think what he's described a case that he saw a term baby admitted with distress, and they managed with as respiratory distress with PPHN, I think with shock. So clinically, I think they suspected that. But he's saying that the echo, when he did that, the pulmonary arterial pressures were normal. They became normal after treatment, but the baby was not, they couldn't wean the baby from mechanical ventilation. The parents withdrew support then, but they also had a history of previous sibling dying with PPHN. So he wants to know what could have been done.
Sorry, I mean, it's a tough case, right? And to be honest, it's very hard for me to tell what could have been done based on just a little bit of an overview. I'm sure if something could have been done, you would have done it. So I'm no way gonna sit here and say you could have done something and change the outcome. But certainly from a PPHN perspective, if the pulmonary pressure become normal after treatment, in the same context, the patient's cardiac function is okay, output is okay, and hypoxemia did not improve, then at least from a PPHN perspective, that was not related to pulmonary patient's ventilation dependency. That's one thing I can say. And I actually can share one experience myself. And sometimes it does happen like that. We've had situations, cases where, for example, in renal anomalies, when there is severe anadromia, or sometimes the patient is presenting with hypoxic respiratory failure or pulmonary hypoplasia. And the question comes, there is pulmonary hypertension, there is pulmonary hypoplasia. Is the hypoxemia coming from alveolar dysfunction or just not having adequate lung tissue? Or is it coming because of pulmonary vascular resistance is too high, causing VQ mismatch? And you can't distinguish the two at the time. I oftentimes end up using carbon dioxide as a marker. If are you able to easily ventilate the patient? Is the CO2 normal? If it is normal, then less likely to be lung, more likely to be vascular. But they don't go hand in hand. And what I tend to do at that time is I tell the family that I cannot distinguish the two. Both can play a role. But what I'm going to do is I'm going to bring the pulmonary pressures down if I can. That tells me two things. One, that the kid is responsive from a pulmonary vascular bed point of view. And second, it will remove that from the pathophysiology. And if the symptoms still persist completely unchanged, then I can tell for sure that this is not related to a reversible pulmonary hypertension and your ventilation dependency is coming from somewhere else. And that somewhere else is pulmonary hypoplasia, which you can't do anything about. Or is it alveolar capillary dysplasia of some sort, or if there's a remodeling of the pulmonary vascular bed because of in utero genetic abnormalities do that. There are various pulmonary hypoplasia syndrome that can do that, and those things are not reversible. But whatever is reversible, you managed. And if the patient refuses to come through, that basically tells you that they are not linked together. That's how I have done it. And I have withdrawn cases like you're describing, not exactly the same, but in the same way, after improving the pulmonary pressure, nothing changes, giving a period of time. So everything that is amenable to treatment has been done. And then you end up being able to in the same position that it's most likely a untreatable cause.
Great. I can take our next question from Dr. Arjun Day. He's a good friend from Bahrain, a neonatologist, and he was in, I think, Toronto as well.
Yes, I don't see his photograph, but I would love to see him again.
Yeah. So his question is specifically, I think, based on your slide, you were nicely showing about the norepinephrine interaction with SVR, PVR, and also the vasopressin effect. So I think he's trying to say that we should be talking about increasing SVR PVR ratio. So basically, we are trying to increasing SVR and decreasing PVR. But he's specifically saying that vasopressin has and nor-AP both have effect on SBP rather than having any reduction in the PVR. But a lot of time it is said that with both drug might have some effect on PVR as well when dropping some PVR. Any what is your experience or any evidence suggesting that?
So the evidence of vasopressin reducing pulmonary or reducing pulmonary vascular resistance comes largely from animal literature. There is some data to say that the vasopressin actually, the mechanism is pretty clear. It acts on vasopressin receptors. And what they end up doing is they end up working through generation of endogenous nitric oxide. I personally don't think vasopressin gives you a clinically important reduction in pulmonary pressure on their own, because these patients are already on INO. If INO was going to work, then it would have worked anyway. But more importantly, is that it does not increase pulmonary vascular resistance at all. It does not cause vasoconstriction, because the vasopressin receptors on which it acts on does not work through a mechanism which can actually cause vasoconstriction. If at all, it can cause vasodilatation slightly, or leave it unchanged. Norepinephrine, on the other hand, definitely increase PVR. There is no doubt about it, because it works on alpha-1 receptors. Those receptors' job is to cause vasoconstriction. But because the expression of those receptors is different in systemic and pulmonary vascular bed, the relative effect that you get can be different. And it also are developmentally regulated, so it also depends upon the gestational age you are working at. But vasopressin, but norepinephrine also has some beta effect. Beta effects are on cardiac primarily, and beta 2 actually cause a bit of vasodilatation also. So depending upon the expression of receptor in an individual patient, you might get slightly different phenotype. But without doubt, norepinephrine increases SBP and pulmonary arterial pressure consistently, but it increases SBP more than pulmonary pressures in a significant proportion of babies, and might be able to bring your PVR SVR ratio down, but at a cost of increasing PVR. So as long as you're confident that you are not going into a situation where the PVR went up so much that even though ratio came down, the VQ mismatch became worse because of more constriction, then you're okay with that drug. And I do use that drug in clinically, but I often use that drug in, as I said, in septic shock induced PPHN. But whenever there is hypoxemia persistent with a patient who might not tolerate any increase in PVR, just because vasopressin is there, like I don't have a better drug, then why take a drug which may give me a different effect? That's how I think. It's about risk benefit analysis, really. Occasionally we have situations where clinicians, because they have never used vasopressin before, or they're a little bit scared, they don't want to, then norepinephrine becomes second line agent, but I have never had a problem.
Correct. Your baby will tell you, baby response will be there.
Yeah.
Okay. Yeah. Okay, Kavita.
Yes. So Dr. Naharmal has asked that at times the right ventricular systolic pressure on functional echo comes maybe more than 100, especially if it is a CDH baby, and the systemic systolic BP is in like 70s. Yet they see shunt across PDA is not completely right to left. So he has
Right.
asked, how do we explain this physiologically? And his
Right.
second question is, how high systolic pressure one can safely drive to reverse the ratio when the pulmonary vasodilators combination have not helped to reduce the PVR?
Right. CDH is a very unique population, and I must say that it requires a little bit of a different approach and a little bit more thoughtful and long-term approach. A lot of PPHN that we manage actually reverses quite quickly. CDH doesn't do that. So because of the remodeling and the pulmonary hypoplasia, and you got to buy time. Now, to answer your question in small parts, the first question was, how do I explain the physiology of the shunt? I wish I could explain everything, but I cannot. But I'll explain what I understood from your question. When you are looking at the pressures of the describing 100 or in the pulmonary artery and 70 in the systemic, you're only measuring the peak right ventricular and left ventricular systolic pressure. That's only one time point in the cardiac cycle, not the entire cardiac cycle. So the pulmonary pressures are not above systemic throughout the cardiac cycle. What you have noted is that at peak systole, the RV pressures are above the systemic, and hence the shunt is going to be right to left at peak systole. But the shunt that you're describing bidirectionality, or not always right to left, is throughout the cardiac cycle. Now, systole is only 1/3 of the cardiac cycle. The 2/3 is diastole. Now, in pulmonary hypertension, the systole may increase slightly, and it may become a little bit more than 1/3. So the directionality of shunt is a relationship of resistance between both sides throughout each time point of cardiac cycle. So that bidirectionality is telling you that in systole, the pulmonary pressures are above systemic, but in diastole, they do come down a little bit, and your systolic diastolic pressure is above the RV or the PA diastolic pressure, so to speak. And hence the shunt is left to right at that time. And that's what gives you the bidirectionality. But from a clinical pulmonary hypertension point of view, we only use definition of peak right ventricular systolic pressure, because we don't typically talk about diastolic pulmonary hypertension, which is a problem in adults, and it certainly is a problem in kids also, but we just don't know much about it. But that's how you're dealing the two, because they're both telling you slightly different things. They're not interchangeable. And from a shunt point of view, there is data from actually done in sick kids a long time back, where they correlated RVSP, the right ventricular systolic pressure, with the shunt fraction in PDA, and try to ask the question, how much duration of shunt in a cardiac cycle tells you that the systolic pressure is suprasystemic? Systolic again, not throughout the cardiac cycle. And they came up with a number of 60%. So if your PDA shunting is more than 60% duration of cardiac cycle right to left, that's an indication that your systolic or right ventricular systolic pressure are above systemic, and then you have suprasystemic pulmonary hypertension. But again, just remember, one time point versus throughout the whole cardiac cycle. To answer your second question, which was how safely can you go, I have no idea.
How high can we go?
I absolutely have no idea. You certainly don't want hypertensive stroke. I certainly will not do more than 100. I will never bring the systolic pressures in a newborn more than 100. 70, 75 is the maximum I have gone to. But you have centile charts that you can use, and it's a tough one. If you have RVSP 100 and your pulmonary vasodilator has not worked, my approach would be give the kid prostaglandin, leave the PDA open, support system circulation, protect the right heart, and wait.
Perfect.
Then that's all you can do.
Thank you. I mean, Dr. Soni is my colleague, so I know which case he's talking about. And couple of times we have faced this situation where numbers are high and we can't really target it above. But just adding to that point, does RV function will affect the directionality? Because if the RV function is good, then you can have a more of right to left rather than bidirectional.
That's true. Absolutely. So I mean, remember when the pump is working, and if you remember you're from medical school a long time back, and I had to revise it every year, to be honest, the relationship between the pressure and the cardiac cycle, the pulmonary artery pressure or the aortic pressure actually goes in relation with the pump function, right? So the systolic pressure in the pulmonary artery is generated by the right ventricle, and so is the left ventricle. If your right ventricle is not pumping, your baseline pressure might be high, but it is not pumping to increase that pressure high. So you actually can easily have a mean pulmonary artery pressure which is high, but the systolic pulmonary artery pressure is low because the RV is not. So every single marker of pulmonary hypertension in the presence of RV severe dysfunction, they become more or less, I won't say useless, but they under evaluate your severity of pulmonary hypertension, including your RVSP, including your PPHN. So once you have RV dysfunction, that on itself is a marker of severity of disease, unless it's coming from some sort of myopathy of some nature, which is rare. But you have to take it in context with that for sure. PPHN can be complete, as you saw in the first case I saw, it was totally left or right, because it just wasn't generating enough pressure. It was complete RV failure.
Right. So great. So moving on to the next question, Dr. Rajat Atreya, I think a lot of us know him from Bangalore. His question is, how often do you see one type of abnormal physiology switch to another? How closely do you monitor echoes and how frequently? Does it help to keep tinkering different pharmacological agents? It's a really relevant question. It's a very dynamically changing physiology. So what's your take on that?
Yeah, I mean, to be honest, I'll be honest with you, not that frequent. The actual underlying pathophysiology, unless something else happened and some drugs actually have sort of misbehaved. Typically in the beginning, especially in typical PPHN, where not CDH, not patient long term, once you establish the primary pathophysiology at that time, that usually is the predominant phenotype at that time. And if you're able to reverse it, you are able to reverse it. I'll be also honest with you, when I started learning this and start doing this, in the beginning, I got it wrong many times. And because of that, it wasn't the physiology changing, it was me changing. So that did happen. And as you do more and more and you become more and more proficient, you are able to avoid those errors in your judgment. In terms of how often the physiology changes, the only, I've had that before, but usually in context of pulmonary hypoplasia, where the pressure passivity disappears after the first couple of days. And instead of having a shunt dependent pulmonary hypertension, it becomes more of a PVR goal. Never as severe as the shunt related, but does stay there. So that I have seen. I have seen function becoming worse for sure. So then you're going down the pathway of getting worsening. And I had a recent case of CMV pneumonia, where the function was perfectly okay, pulmonary pressure was quite high, and we focused primarily on trying to bring them down, but they didn't respond. And the patient's right ventricle became more and more dilated. And 24, 36 hours later, the physiology changed because the RV dilatation, physiology didn't change, it progressed. And the RV dilatation compresses the left ventricle completely and was ballooning out. And all the pulmonary vasopressors were actually, vasodilators were failing. So we started the patient on prostaglandin. 8 hours later, his RV was half the size and the function has improved. And the next day, patient has completely normal cardiac function just by offloading with prostaglandin. And then we had to wait, just had to wait till the CMV got better.
So if you can summarize, like daily echoes are probably must, but anything changes clinically, then you probably might be good to repeat.
Yeah, and sometimes when you are not sure, if you are not sure what your underlying prominent pathophysiology is, then you try and reevaluate 3 hours later to see how things have changed. Or if you're not sure that your therapy has worked. So pre-post, if therapy has worked, I go to sleep. But if it hasn't worked, then I have to stay at the bedside.
Correct. So your baby is your best teacher. Okay. Over Kavita.
Yes. So, Dr. Arjun is asking this group of BPD with chronic pulmonary hypertension who are oxygen dependent. We empirically use sildenafil with variable response. So he's asking, what is your practice in this type of situation?
You are trying to get 2 lectures out of 1 here.
Yeah, that's correct.
It's a completely, I do actually give a bunch of talks on that, and we do actually have a management algorithm that we use here. And we have published our outcome data based on that for the last few years in pediatric pulmonology about 2 years ago. It's an active research area. It's completely distinct. First of all, BPD-induced chronic pulmonary hypertension or anything induced chronic pulmonary hypertension, including CDH or other pathophysiology, that's not PPHN. PPHN is an acute pulmonary hypertension crisis occurring in birth. It's completely different pathophysiology, totally different cardiorespiratory adaptations. You almost never see PPHN physiology in BPD induced unless they are near death, to be honest. Because chronics increase in PVR is much different. So it's a very different physiological talk that I have a whole talk on, but and I'm happy to give it at some point in future. But to answer your question in very brief, because you've been kind enough to tolerate me for so long, we don't use sildenafil that much. What we tend to do is we tend to evaluate every at-risk patient at 36 weeks. We diagnose their pulmonary hypertension, chronic pulmonary hypertension, different criteria early. And the moment they have RV dilatation or evidence of pulmonary edema, we first give them diuretics. And our experience has been, and as I said, we published it also, and we are right now in the process of publishing our physiological data of pre-post diuretics. They improve quite dramatically with diuretics because pulmonary edema is a major mediator of chronic pulmonary hypertension and symptoms. In between, pulmonary edema always play a role. And that's known in adult cardiology, that's known in pediatric cardiology. So we first give them that. And after that, if they are still progressing, we give them sildenafil. And I have only used sildenafil. So we get about about 200 patients, less than 29 weeks in our unit every year. My use of sildenafil is about 3 patients a year. I've only had 1 or 2 who did not respond and continue to progress and actually end up dying. But the rest do settle down with diuretics and eventually sildenafil.
So which diuretics do you use? The furosemide or hydrochlorothiazide?
See, you're getting a whole talk. Yes, I use we created our own sort of recipe, so to speak, and I created it because we are diagnosing them a bit late, where they already have pulmonary edema established. We first give them actually furosemide. And we are giving oral, not IV at that stage. So because we're giving oral is half bioavailability of IV. So we double the dose. So we tend to give 2 milligram per kg twice a day for just 2 or 3 days. Acute diuresis make them lose a bit of edema and their symptoms improve quite dramatically. And after that, we change them to aldactazide for maintenance. And if after a week or 2, slowly they start getting more, then we add a little bit of Lasix for maintenance, a bit like VSD management. But we don't use long-term LASIK in this population. Number 1, we haven't had to. And number 2, they cause unnecessary electrolyte imbalances.
Right. So just, on the same context, one question I had skipped for coupling together by Dr. Norahin Ibrahim. He's asked about what is your strategy to taper of oral sildenafil. Now, this question is applicable for BPD, but also, like, in many centers, there is no nitric oxide. So often people ask this question, if you're on IV sildenafil in acute PPHN or changing to sildenafil, do we have to slow taper off or rapidly you can come off if the baby is clinically well?
Yeah, nobody really knows, no? That's the problem. Because there is just not enough pharmacokinetic data in these things. But you are really talking about it no different than INO. When you stop INO, you know you're going to have a rebound hypoxemia because you've actually removed the patient's endogenous nitric oxide production. But it takes 4 hours. You can actually time it by the clock. It takes 4 hours for it to recover. If you can tolerate 4 hours, you can. To answer your question about IV tapering, it depends upon the patient. If the patient's pulmonary vascular bed has dilated, then and the hypoxemia resolved. Because the PVR and hypoxia are quite closely linked. So what happens is you have vasoconstriction, hypoxia, then hypoxia further causes PVR to keep going higher and higher. So it's a vicious cycle. Once you break that, hypoxemia improved, then your PVR is not going to go. It's not like a elastic. Like once it's relaxed, it's relaxed. And then you don't need to actually stay on treatment for long. You can wean quite quickly. You can completely stop it, but you are going to have a little bit of rebound, I would suspect. You can cut down to half, 1/4, and you can do it every 6 hours. As I said, 4 hours the time I give after weaning something, because I know patient is going to show up in 4 hours. So every 4 hours, I wean it off. Once your job is done, his job is done. What you don't know is the patient dependent on the drug or not, right? And the only patient can tell you. Majority of patients are not. Once you turn them around, they're not dependent anymore.
But in cases of CDH and pulmonary hypoplasia, so you can see sometimes they're on long-term dependent on oxygen. So in those cases, how you wean?
Right. I don't do CDH in Sambhavan Sana, as you know, Kiran. So I wouldn't be the best person to tell you the long-term CDH, but for a BPD ones for sure. We tend to be a little bit more cautious with them, especially if they're not having any side effects and they're tolerating it quite well. We don't use too high dose anyway. The highest we have used is 3 mg/kg per day. Occasionally for IV, I have used up till 6 for acute, but for chronic, I'm 6 only one time, Kavita. Not routinely.
I can share my experience with that. I mean, we had 42 diaphragms in last 3 years. So I think we put most of the CDHs, if they have persistent pulmonary pressures, we on oral sildenafil and try to wean as long as they're needing the oxygen, and then obviously guarded by echo. As long as there's some degree of echo pulmonary hypertension persisting, we tend to keep them on sildenafil and then slowly wean. We tend to give them a high dose of sildenafil, and then it's a gradual wean over days or sometime even weeks. Specifically for pulmonary hypoplasia and CDHS. And I think, BPD, as you rightly summarized. For acute,
I know what cardiology does the same thing. So even for diuretic for BPD, I have to send them home on diuretic because they improve quite a bit and their pulmonary pressure is still the same. Same thing happens. I collected our data. I was saying we published it. The average, the highest time the cardiologist left them on diuretic was 1 year. And for a sildenafil, few patients that we end up doing was about 14 months. So what they end up doing is coming off oxygen is a major marker. And they just call them for echo every 2.5 months. And then there is if all evidence of pulmonary vascular disease has resolved on echo, you're pretty much safe. Right. Because it doesn't normalize your pulmonary pressures. It reduces it, and it improves your symptoms, but you still have a degree of flattening in diastole. You still have a pulmonary artery notched presentation because none of these drugs completely normalize your PVR. It just reduces them. So once you have complete resolution of PVR markers on echo, that usually means resolution of disease. And if your disease is resolved, then you don't need the medicine for it.
Correct. Perfect.
So,
Kavita,
yes. So I think Dr. Soni from Dr. Kiran's unit, she's asked
you are
on
not
CDH.
Speaking to your colleagues much. They're asking me all the questions.
No. Dr. Soni is also one of the expert in PPH, and he gives.
I know.
He's very interested in the topic. Yeah.
I'm sure he's just trying to pull my leg here.
So he's asked about CDH only, saying that they have coexisting myocardial abnormalities. So the physiology of various drugs used in PPHN without CDH versus with CDH is different. So what would be the different approach in your experience?
It is thought to be different. One of the things about CDH population is that, and I haven't yet seen the data to be absolutely convinced, but certainly speaking to experts and or reading the reviews, is the LV diastolic dysfunction that these patients tend to have, or they have a little bit smaller left ventricular function, and their diastolic performance tend to be a bit inferior. So my personal experience, and I've had few CDAs that I've managed, but I know my friends who follow the same physiology who manage CDAs. And I was speaking to my friend Patrick just day before yesterday, actually. He's moved to Iowa right now, and they have now CDHs in the ICU. He's been managing CDH for last 4 years using the TN echo, and we both talked about it, and we didn't think there was a lot different in terms of underlying acute pathophysiology. The duration of illness is for sure different. And the response you get is definitely different, because you don't turn them around, bring them to room air in 4 days like the cases I showed you. That doesn't happen. But the use of vasopressin, they've increased quite a bit. He's going to publish his data in the next year, promised me. Since they have done that, their improvement in improvement in oxygenation and reduction in ECMO use has gone up quite a bit. They're not using ECMO that much because they're able to oxygenate much better. Ever since they start using vasopressin in CDH population also. So I am not entirely sure how much is the difference and how much is the historical one that we just haven't taken that leap. to go forward with them. But I have no doubt that there has to be some differences because their myocardial function is different, particularly diastolic performance, which we don't really know how to measure very well, to be honest. Milrinone has been suggested. So one of my other people I speak to quite not very frequently, but he gives talks to us is Neil Patel from UK. He does work in CDH quite a bit, and Milrinone seemed to be his favorite drug in that population for the same reason. So I think at the end of the day, it's about symptomology, right? Hypoxemia improvement, normal perfusions, and then waiting for the lungs to grow. That's what you're trying to do, really. So that's the best I can tell you.
Sure.
I guess you have more experience than I do, and I knew you were going to put my leg on it.
No, I think that's useful. I'm just jumping to question. I think there are questions about again, what are the drugs of choices in a resource limited setting where I know it's not there, whether we can use sildenafil, bosentan.
Yeah, I mean, I don't see why not. And I know that's also often a consideration in especially with the expense that it comes with. I mean, you guys have more experience of using sildenafil in acute PPHN than I have. But I don't see why not. The small trials seem to show that this has equivalent effect. It does sort of look at the same pathway, which is cyclic GMP pathway. So it targets the same pathway. It's about delivery. You're delivering through intravenous route versus inhale route. So it can make your VQ mismatch worse if you are not well aerated. So that's something to always keep in mind, that if your lung alveoli is not well recruited, you vasodilate. So, vasoconstriction around a not recruited alveoli is body's mechanism to preserve VQ matching. And if you forcefully vasodilate and send the blood to the area that are not aerated, you can get a worsening. So as long as you're watching out for a worsening in oxygenation, which can be because of poor VQ matching, particularly meconium aspiration sometimes, you're going to have VQ mismatch because areas are not aerated and you can't even reach there without bashing the lungs down. So it becomes a bit challenge because how do you vasodilate all the lung? So just watch out for that. But I don't see why not. Magnesium sulfate is another thing that has come through a little bit. I have used it a few times. I haven't had any response, but I only used it in patients who were terrible, who just didn't respond to anything. But the data suggests that it should induce, and it's reasonably cheap, available quite widely. The biggest side effect you got to watch out for is systemic hypotension and VQ mismatch becoming worse. So if you can make arrangements for that, for example, we oftentimes end up using vasopressin, sometimes prophylactically, simply because we're using Milrinone and we want to use Milrinone, but the blood pressure is quite soft and we know it's going to drop down by 5-6 and kid will become hypotensive. So we give vasopressin for 2-3 hours, bring the blood pressure up a little bit, not hypertensive for sure, and then give vasopressin and then give Milrinone, so that you actually are able to tolerate that combination better. So that certainly can work with the systemic pulmonary vasodilators. But you got to figure out your own recipe as long as you're aware of the pros and cons.
Correct. And bosentan, Dr. Purushottam had whether bosentan probably in PPHN acute setting. I think there are only a couple of trial, one from Pakistan and one from Egypt. I think not much, right? Yeah.
I mean, the biggest question you have to ask is how big a role endothelin plays in PPHN. Does it play? I mean, that much of a role? And that data I haven't seen. There is data in sepsis, acute pulmonary hypertension, where they have demonstrated that in sepsis-induced later onset pulmonary hypertension, the endothelin levels are quite high in the tracheal aspirate, but the nitric oxide levels are normal. So, which is why, and I don't know what your experience is, in my experience, the acute pulmonary hypertension crisis in sepsis and neck later on, I know almost never does anything. And it does not improve your hypoxemia. And that could be because they don't have a problem of nitric oxide production, which is what transitional babies seem to have. But they may actually benefit more with something like endothelin 1 receptor antagonists, because they seem to have high endothelin concentration. But some patient might. But if the data from transitional circulation tracheal aspirate analysis have demonstrated that these patients who are hypoxemic and PPHN tend to have lower nitric oxide in general, which is a major variable in transition. So which is why nitric oxide sort of seem to work better, or cyclic GMP pathways seem to work better. So I wouldn't use bosentan as a first line for sure. I would rather use sildenafil. But if something is not working and you as a trial because you just don't know which pathway might actually help you, I have never used it, just to be honest. This is all theoretical. I'm just pontificating here.
Right. I think we are using
Yeah.
it as second line in chronic pulmonary
Yeah, in
hypertension.
chronic, because also oral. There's no IV medications.
Oral, yeah. There's no IV. Yeah,
It becomes also a challenge.
correct. Yes,
So,
Kavita.
yes. Uh, so in one of the case scenarios, you mentioned bicarb was given, so that a lot of questions have been asked regarding that because yes. So
Hot topic.
yes. So if the lungs are recruited well and volume status seems normal, but still your pH is low, so would you give soda bicarb to improve pH
Right.
so that
Right.
cardiac drugs?
So first of all, I didn't give it. My colleagues give it. So their fault. Second, you're never going to get a trial of bicarb, right? So bicarb is your acidosis is a symptom. You got to always ask from where it's coming from, right? So as long as you can diagnose that. So if you have a low cardiac output giving you acidosis, I'll fix the cardiac output rather than the acidosis, right? Because if you improve your circulation, you are going to improve your acidosis on its own because it's a delivery issue. Now, having said that, once your back is up against the wall and you are dealing with situations, you aren't gonna actually hold back on things as much. And we do end up giving bicarb to correct acidosis because we presume it is very clear, as you saw from the pH slide I showed you from 1960s Rudolph experiment, pH does increase PVR. Low pH will increase PVR for sure. The question is, improving that PVR by giving soda bicarb, will that reduce? And the answer is yes, it does. And PPHN literature is quite clear. There was a big study, a cohort study published from US comparing hyperventilation or alkalosis using hyperventilation versus bicarb infusion and the impact on PPHN. And they demonstrated that both those strategies work. But alkalosis from hypocarbia caused PVL in the brain, while bicarb did not. But they also came up that too much alkalosis is not required. So perhaps just keeping the pH in normal range is good enough. So that's what we tend to do. So giving a bicarb in a tough situation is for twofold. One, to reduce the PVR contribution of acidosis without causing alkalosis. In our PICU, they still sometimes to prevent ECMO, will give bicarb infusion round the clock just to keep the pH at 7.45. Because the PVR effect. And I'm not sure that I subscribe to that idea, but they do tend to do it based on the data I was telling you before. And second thing is the myocardial dysfunction. So the acidotic environment is not great for myocardium. So that is also another problem. Now, does bicarb giving makes a difference or not? I don't know, right? You're always going to have animal literature. You're never going to have human literature on that. What bicarb does do is once you give, it's going to increase your CO2. That is for sure. So you have to preempt that and increase your amplitude so that your CO2 doesn't become from 60 to 80, because it will because it produces CO2. And the bad name the bicarb got because of people saying is actually the studies coming from hypoxemia and cardiac arrest at birth, where they talk about bicarb improving acidosis but worsening intracellular acidosis. But the data is not PPHN data. That data is in the context of birth asphyxia. Because bicarb used to be a part of resuscitation. Bicarb and dextrose both used to be a part of resuscitation drugs, which they have taken out ever since. What they're basically saying is that from asphyxia point of view, it doesn't help. But this is not asphyxia. This is not acute bolus of bicarb in asphyxia place. This is essentially a little bit more. So I don't know. The short answer is I don't know. The long answer is that I would find it hard people not to use it when they are struggling and they have a high PVR and myocardial dysfunction and acidosis. Obviously, you're not giving a truckload of it. It does reduce PVR. That data is clear. Whether that changes something clinically or not, I don't know.
Right. So we have already gone over time, but I hope we can have another 10 minutes or so. Lots of questions still left. A lot of discussion.
No worries. I'll send you my bill, man.
To Manoj.
Send it to Kiran.
So 10 more minutes we can take. I think question about ECMO, what are the babies indication or which babies end up on ECMO? There's a couple of questions asked related to ECMO. What percentage of babies end up on ECMO? And has targeted echo affect the number of calls to decrease in the ECMO?
Right. So that's an interesting thing. And I am not boasting or anything. I have never had to send a child on ECMO. in my own practice. I've never had a child of PPHN who either died from PPHN unless they had underlying remodeling from renal agenesis, or I had to go to ECMO for PPHN. We've always been able to turn them around using TNE. And now that's just experience. The experience from our colleagues is not very different. The ECMO criteria is typically oxygenation index more than 40, you end up referring. Our rate of ECMO for PPHN in non-cardiac, non-CDH patient is virtually next to nothing, maybe 1 or 2 patients a year. They do end up getting referred to PICU because the OI is high and they're not responding for query ECMO, but they end up getting bicarb infusions, they end up getting things, and they end up not going on ECMO. Majority of them, it's very low. Having said that, it's also because our meconium aspiration rate is quite low now. So that has played a big role in reducing the need for ECMO. Has TNE reduced ECMO? Apart from me shouting from top of my lungs saying, yeah, I have, there's no data. But again, as I said, Patrick from Iowa is working on it, because once he went there 4 years ago, they set up a TNE program, which they never had before. And they had ECMO and CDH and population already there. So they have baseline data of their ECMO rates. Ever since last 3 years, they have managed every PPHN using TNE. So I'm actually myself looking forward to that data, that what happened to their ECMO rate. But remember, ECMO rates are so small. To show a statistically significant difference, you need 5, 7, 10 years. So it's not as if it's something which happens so frequently that you can actually show a difference pre-post in 1 or 2 years, right? When you're only sending 5, 7 patients to ECMO a year for that particular pathophysiology as a baseline, even if you remove from 5 becomes 2, that doesn't really excite people. So we'll have to wait and watch. He tells me that he has, but that's just him and I being biased.
Right. No, that's great. I mean, our center is an ECMO center. We have done only 5, but our ECMO people are now buying for TNE, more than are going for ECMO. So definitely it is the number is reducing, and I think the outcomes are better with TNE managed this thing. But sometimes, you have a significant cardiac dysfunction and these babies are not pulling off, then they end up, and some severe CDHs probably sometime end up on ECMO. So I think a couple of more questions. Just one specifically has mentioned PPHN with LV dysfunction, inotrope of choice. I think you mentioned epinephrine, probably with melrinon, isn't it? That could be the thing. One interesting question: Down syndrome with hyperleukocytosis and PPHN. How do you manage that?
Well, I don't have to manage it that often because it doesn't happen that often. It does happen, but not that often. My friend Afif, who works in Dublin, has interest in Down syndrome physiology and has published a few papers on it, and conducted some studies using long-term. I mean, Down syndrome becoming a PPHN crisis at birth is not as frequent as people think it might be. They have high pulmonary pressures, yes, but they're not in hypoxic respiratory failure with it. I can count on my one hand the number of cases we have had in like 12 years here, despite having 8,000-10,000 deliveries a year. They are born and they are usually okay. At best, they have a bit of TTN type picture or mild transitional problem needing oxygen. Majority of them don't have PPHN. So I don't have the bulk of experience to actually tell you in detail that this is how it should be managed. And I don't think any center would have that number of patients. But theoretically, from a physiological standpoint, the management doesn't change a lot. From a PPHN perspective, the physiology is not much different. Leukocytosis is an interesting point because that increases your hyperviscosity syndrome becoming a role player. So that's a unique consideration, because if you're hyperviscosity, if you look at the PVR calculation, viscosity is an important part in that, which is why polycythemia can be an important role. But leukocytosis, when it's really high, like 150, 140, or something like that, leukocyte count, it can give you a contribution to increase viscosity enough to actually cause high pulmonary pressure in addition to other problems. So how do you manage that? Can't do much, man, except for giving good fluid hydration and bringing the viscosity down.
Yeah, you can try exchange. I think we tried exchange in
but it's white cell count, right? So they just keep getting reduced.
It doesn't help. Yeah, we had actually leukemoid reaction or leukemia, acute leukemia with Downs, where just acutely it could reduce the number still from 200,000 to 90,000 just with the exchange.
Yeah, we have used chemo a couple of times,
Yeah,
but not for
correct.
PPHN, but in general, because it
Yeah.
actually has a risk of stroke with it.
Right. So,
Clearly, you guys have more experience in weird and wonderful things than I have. I barely get to see much.
yeah, Middle East has a lot of anomalies, right? Yeah. So Kavita, you asking, I think
Yes.
just a couple of questions left now.
Yeah, so quite a few questions on if we don't have INO, what do we do? So I think we covered that, sildenafil, Maxulf. I have one question, Professor Amish. So there was the case series that you mentioned, preterm babies where INO failure in HRF, you use vasopressin after INO failure. So in a setting without INO, preterms with HRF, can we do vasopressin earlier?
Yeah, I mean, why don't you do a trial? Then you actually can generate the data for us. Because you have done trials on sildenafil versus INO, sildenafil versus nothing. Yeah, I mean, again, it's physiology, right? I mean, we are not using vasopressin for pulmonary vasodilatation, right? We're using vasopressin in complicated cases where you need a blood pressure support without worsening PVR and you're altering the ratio. So the question you're asking really is, can PVR SVR ratio playing with it particularly? So PVR SVR ratio can come down two ways, right? Either you bring the PVR down, which is by INO or sildenafil or whichever means, right? Or you bring the SVR above PVR or a mixture of both, right? Vasopressin will just do this. It won't do this. So I personally wouldn't use it as a primary go-to drug in a patient who has got a high PVR. You can easily solve the problem by just vasodilating. Then you are trying to get there in a different, more difficult way. Because this is going to get there also, but in a more challenging way. But we can easily bring it down, improve VQ matching, hypoxemia gone, acidosis gone, patient goes home.
That was so simple.
No, I mean, that's what INO patient does. No, sometimes 20, 25, 30% INO patients I don't even see because, they have got this. Patients start INO, an hour later they are in room air or 30% oxygen. Next day they are off INO and so on and so forth. Same thing. When I say INO, I mean pulmonary vasodilator, exclusive. You certainly can use vasopressin in combination with sildenafil because it will actually help you avoid the vasodilatation of the systemic circulation bed that you're going to get with sildenafil. So then combination makes a lot of sense because then you're dropping the PVR through sildenafil, but its effect on the systemic vascular bed is counteracted by a drug which also helps PVR SVR ratio. So we tend to use milrinone and vasopressin combination, but sildenafil vasopressin combination in the absence of INO makes total sense from a physiological perspective, at least. But alone as a first line drug, I don't know how much you're going to get. You might get improvement in some, but I would still think it's a more twisted way to get to the problem when you can easily get to it directly.
Right. Okay. I think we are coming end. Maybe Dr. Soni has been asking a lot of questions. One interesting question again he's asked, and I'll add
This is my cell number.
I know. I have your number. Yeah.
You have
but
my
I think
number.
interesting. He's just making an interesting point whether measuring the VTI pre-postductally saying can help in quantifying, like we do VTI for RBO, RBO. Whether we can do VTI for PDA to quantify the shunt. And one more question I'm adding myself, I always have. Sometimes we know that baby has PPHN and there is a bidirectional shunting in PDA, but there is no TR. And despite having a good RV function, sometimes with RV dysfunction, you don't get TR, but sometimes you don't get TR in an acute phase. Why is that? These two things you can explain.
So why we don't get TR?
Sometimes you don't see a TR, yeah.
I know.
Is there
People have demonstrated that the TR is usually absent in acute phase in about 30% in the very first time. And as you see them next day after, it becomes even more and more absent. Right. And in chronic cases, it's absent in about 70%, only present in 30%. Right. And why don't patient have TR? It's hard for me to explain, to be honest. But that's the reason people have done studies to try and find alternate measures. So patients who have TR for sure, if you can use them as gold standard and find the other marker which correlate, which is why that 60% PDA shunt duration, the study was done for that reason, that to learn from the patient who have the gold standard to try and use the marker in the patient who doesn't have it. Why you should have TR or not have TR depends upon multiple factors, right? I mean, it's not just the pressure game. It's also how leaky the tricuspid valve is going to be, how dilated the myocardium is. Because if it's dilated, you're going to be more likely to have TR than less likely to have TR. And also you have TR, but just not seeing it on echo, right? I mean, echo doesn't pick up TR all the time.
Correct. And the VTI, do you think any value of measuring VTI and PDA?
I don't know. I don't know. Depends what question you're trying to answer, right? So if the question is, does pulmonary pressure are higher than systolic? That by duration people have done. So if a study can come through showing that a certain VTI actually correlate in, then yes. I don't use it right now because I don't know what to do with the numbers. In terms of if the question is there significant runoff? If that is the question that you're trying to just how much volume getting off, then there might be some value. But again, we don't know where is that threshold. Right now, we are using qualitatively by just looking at it, small, large, small, large. I find pulmonary vein velocity really, really useful in that because there is just, right upper pulmonary vein, you can easily measure in four chamber view directly. You get the velocity straight away, and there is no, in a PDA, the VTI depends upon so many factors, like the diameter is different. Where are you measuring across the whole duct? If it is restricted, the VTI comes out as like 50, but the volume is much less. So that relationship between diameter, restriction, architecture, and the VTI, that will need to be sort of standardized for that purpose. But we just don't have the data to say what do we do with it. But I can make sense. If there's a really small VTI and then you can say this is a very small runoff versus a large VTI is a large runoff. It's similar to what we see in the picture, a large right to left versus a small right to left component, right? So yeah, I mean, that's where I am with it.
Right. So I think, Dr. Kavita, there are a few questions related to BPD. I think we should reserve it for the next talk of Amish.
Yes.
I've already given my
Yeah,
thought.
we should.
So
We will
I
do
think-
that in the IAP Prof Amish has agreed to come for that, so we will have it there. I think before
There you go, Manoj, you got me. I have a question for Kavita actually. How is Goa?
In terms of what?
In terms
COVID.
of working there, it's one of my favorite, it's one of my most favorite places on earth.
Yes, Goa is very beautiful.
It must be fun
How it is
working
in terms
going
of
to beach there, Benu.
yeah, must be fun working in Goa, no? After rounds, go on a beach.
Oh no, not like that. No.
Kavita, he is indirectly asking you to invite him over there.
That's true, Naveen. Thank you so much.
Correct.
Yeah. I have your number. I have a number. I will do that.
Good to have number at least for this use, not only for asking question and answers.
True.
so
Okay, I think I
let's
got to
talk
head back to
about
the
the-
unit.
yeah, with the permission of both Dr. Kiran Murray and Dr. Kavita, before we will close the session. Is that okay?
Yeah, sure. We
Yes.
left out a few questions. Unfortunately, maybe we can type it in the chat box while we are summarizing. But
Even mail it, I will forward it to the Prof Amish, and we can find a way to address this question. PPHN will be again discussed. We had discussion on PPHN last year in the series. If you remember, the third lecture was by Prof Satyan on PPHN, lessons from the fetus, and we will continue to discuss this. And I'm sure the discussions will go on. The topic is like that. So before we go for the vote of thanks, I invite the president of IAP Neonatology chapter, Dr. Naveen Bajaj, to make an announcement regarding the upcoming national conference IAP Neocon. Over to you, Naveen.
Yeah, good evening, everyone. It was very informative talk, Dr. Amish. And as Kiran has already said, that every time you listen to PPHN from different speakers, you tend to learn something new. And thank you so much for giving us the time. And I'm sure Manoj is going to invite you over there for our upcoming IAP Neocon 2021. So unfortunately, because of COVID time, we have to cancel that IAP Neocon 2020. And but the good thing was that we started this very a beautiful and interesting learn from legend session, and that idea came only after that when we had to cancel that conference, right, Manoj? And it was a good idea and supported by the local organizers, Manoj and everyone, and all the IAP Neonatology chapter office bearer. So probably for last nearly 1.5 year, we are online learning from true legends, obviously. But this time we are thinking and we are quite hopeful that we are going to meet all of them soon in coming March 2021, and the dates are 10 to 13th March 2021, and the venue is Manoj city and Kerala, and there are it is very beautiful. Kerala, you all know that it is God's own country, and Trisur Manoj is a very good host also. And he has planned so much yoga and cricket session and so much he has planned last time, but unfortunately, and I'm sure this time we are going to do it, Manoj.
We will, we will. God willing.
All our good wishes are with you, and I invite all our legend speakers first to come there, and Manoj is going to be a very good host, definitely, and all the participants to join us for the conference from 10 to 13 March in Manoj's own city, Thrissur, Kerala.
Thank you so much, Dr. Naveen. Friends, we come to the end of today's session. And as we all know, the sweet things go on and on. We have had sessions like this. We had our scheduled time. We were supposed to wind up an hour ago, but then because of the interest in the topic and the excellent faculty we had, and of course the excellent moderators, session went on and on. And this is something that we always cherish. And it's surprising to have most of the people stay back till the end also, and then the reviews that we get after this is also highly encouraging. So we come to the end of this session. Before we close, I have the great honor and privilege to thank you all. First of all, the faculty for today, Prof Amish Jain. He is one of the great speakers you must have realized by now. And his talks, I always loved his talks whenever he talks on TNE series and all that. So thank you so much, Amish, for joining us today. It was an honor to hear you.
No, pleasure was all mine. Thank you so much.
Thank you so much. We look forward to meeting you again.
I look forward to your cricket things in Kerala.
Yeah, we are planning to have interstate now we have maybe even a higher level also we'll have a cricket tournament. We will have some extracurricular activities as well. Anyway, let us see how the COVID decides things.
You may have international match now.
We will have
international faculty versus national faculty.
Some other. So thank you so much, Amish. Now we had this discussion was so wonderful because of the great moderators we had. Dr. Kiran Murray, whom we all know is already a speaker on hemodynamics in our India. So he's and plus Dr. Kavita, she has also done excellent work. And so because of Dr. Kiran and Dr. Kavita, we had a wonderful discussion today. Thank you so much, Kiran and Kavita.
Thank you, Manoj.
Thank you.
Last but not the least, I would like to thank sincerely the 7,000 registered delegates we have for the series who have come at some time or the other, and then some. This is a huge honor for us to host you. You have joined us from different parts of the world. It was a huge honor, totally a huge honor for us to host you. Thank you so much for joining us. I would also invite you to join us next week. This time, because of Professor Vento's timings, we had to advance the session one by week. So Professor Vento, the legend who gave us a lot of values like 30% FiO2 for resuscitation, things like that. He is going to talk to us about the approach in oxygenation of the fetus and newborn. That's going to be at the same time next week. 7:30 p.m. Indian time next week. I would invite you all to join for that as well. Until then, good day, good night.
Thank you, guys.
Thank you again.
Thank you, everyone.
Thank you, everyone, for joining. Thank you.
Thank you.
Cheers, Amish.
Thank you. Good night.